Okay, we're going to continue with the need for healthcare reform, looking at the moral and the ethical issues. Looking at questionable insurance practices, the U.S. allows private insurance companies to profit from providing basic healthcare. Unethical business practices can only occur in insurance companies because they are run by humans, so decisions are made that, for example, low quality policies can be sold that are short term, or they have limitations in their policies. So again, decisions, unethical decisions, they come from humans, and that's where the problem can lie. Insurance companies also increase profits by selectively withholding services and delaying or denying services. We know that the purpose of insurance is to spread the risk across a large pool of people. It is acceptable that some people will have more care than others. We know that the unforeseen medical needs is what usually, of course, makes us use the insurance policies. And again, that larger pool is more beneficial to the whole. The insurance companies, they have also added policy limit caps to their policies. So you can only use a certain amount of funds based on their policy limit caps. Rescission, it's a legal term that is used when a health insurance policy is canceled unilaterally by an insurance company without the knowledge of the owner of the policy. The Affordable Care Act allows an insurance company to cancel a policy only if that patient has committed fraud, or if the patient lied deliberately about a material fact in some way that prohibited in the way that it was prohibited in the term of the health insurance plan. The Affordable Care Act also made it illegal to deny insurance for pre-existing conditions. In 2008, the Congress investigated into the problem. They did an investigation into the problem of rescission. They found insurance was being canceled retroactively, and 3 of the largest health insurance companies in the nation were called before a congressional committee. They found that these companies were saving more than $300 million between the years 2003 and 2007, just by practicing the canceling of policies. Some of the findings in this 2008 congressional investigation of health insurance rescissions revealed that rescinding coverage on the basis of typos in application form was one of the reasons. Also, the basis that an individual failed to disclose conditions they were unaware they had. Family members incurring high cost claims, even if they were not involved in the omission or the discrepancy. They also investigated medical histories of all their enrollees, those that were diagnosed with certain high cost illnesses or conditions. They were doing investigations. Furthermore, the evaluation of their own employees, it was a basis of how much money they saved the company by retroactively canceling policies. And then they used their computer information and an algorithm to identify women that were recently diagnosed with breast cancer, to trigger an investigation to see if there was any pretext to rescinding the coverage. A couple stories. One in Texas, a nurse was diagnosed with an aggressive form of breast cancer. She lost her health care insurance, and the reason that was given was that she did not disclose a visit to the dermatologist for acne many years prior. So the insurance company, they considered this a pre-existing condition for cancer. Patient with lymphoma was also found. He actually had passed away, but his sister, I believe it was his sister, had testified saying that her brother had already had approved life-saving bone marrow transplant for lymphoma, and they also rescinded on his policy as well, saying that he failed to disclose or report that he had gallstones, and also the possibility of aneurysm that showed up on an x-ray. It was actually on his chart and an x-ray that he had several years prior. That x-ray was never discussed with the patient, and that patient, during the investigation, they found that there was no deception. But too late for him because he had already passed away. So denying claims and patients are suffering because of the rescinding of that policy. Insurance regulatory issues. Although insurance regulation is primarily delegated to the states, the federal government often writes federal policies or protections that are supposed to be incorporated into the state regulations and enforced. So for example, HIPAA, the Health Insurance Portability and Accountability of 1996, this policy you will see at the state level as well. So we follow HIPAA, we follow those regulations and enforce those. Lack of information. So the states do really a poor job at collecting information to really know what's happening in the insurance market. It was believed that the federal policymakers should address the regulation of health insurance markets, and they had some recommendations in which they wanted to implement so they could continue to, so they could regulate. To the extent states continue to regulate insurance under health reform, states' laws must clearly and consistently reflect the federal standards. So that, which is what we would want as well. We want to make sure that the federal, the federal regulations are incorporated at the state level as well. Expanding direct outreach and support on consumer rights. Another recommendation is regulators must collect more data, detailed data about the health insurance market. They regulate and use specific criteria. Whenever they carry out a market conduct review, they need to have specific data in which they're going to be reviewing and looking at. So, and then also the federal government must also take a larger role in the protection consumers. So those are the four recommendations for regulation of, looking at the health insurance market. So that's kind of double, it has like two things going on there. If you've got a private insurance market, so we know that they have the ability to make money. And so in this case, they are denying people, rescinding policies, so they are saving money and they're rewarding employees for saving money. However, what is happening here is then the consumers are not getting the coverage in which they need. So this forces the government almost to get involved in regulations because we have this financial incentive to carry out the unethical behaviors of the insurance companies. So anyway, that can be one of two ways. You've got a lot of people who do not believe that they want more regulations, but yet we don't want consumers to also be in a position where they don't have the insurance that they need to get the care that they need. So again, that moral compass, sometimes greed takes over, causing very unethical decisions to be made toward our healthcare, of the population. So. The debate, healthcare reform is going to continue. So if we look at all sides, they agree that there needs to be a way to reform the healthcare system without causing an increase in the gross national product, which is basically the cost. So trying to keep from increasing the cost of goods produced and services provided by a country in 1 year. Successful reform. Where does it begin? Number one, knowing that there is no perfect system. There's no perfect healthcare system. Reform needs to be accomplished in a reasonable amount of time and also at an affordable rate. Looking at different solutions, a variety of solutions, of course, it meets different needs and also different sets of priorities. The goal is, however, to have solutions and measures to improve the system while addressing the priorities of cost, quality, and coverage. Looking at the American Nurses Association and their position on healthcare reform, they actually have a strong commitment to its belief that healthcare is a human right. All persons should have access to affordable, high-quality healthcare services as is needed. Looking at the updates, there are some updates that have been made to the initial American Nurses Association documentation, which include the ANA reaffirming its support for restructured healthcare system that ensures that all citizens and residents have universal access to essential healthcare services. The ANA believes that development and implementation of health policies that reflect those 6 aims of the Institute of Medicine, which is safety, effective, client-centered, timely, efficient, and equitable provision of care, is going to be based on outcomes research, and it will ultimately save money. So using that framework is important. The system must be reshaped and redirected away from the overuse of expensive technologies that's driven, that technology-driven care. Acute, this also needs to go away from acute hospital-based services. So they really want to invert the pyramid of the priorities and focus more on primary care. Ultimately, the American Nurses Association, they support a single-payer mechanism as the most desirable option for financing a reform and reformed healthcare system. Moving from that system that provides illness care to one that provides client-centered preventative health care. So if we look at 7 out of 10 Americans, they die from chronic disease. And 50% stroke accounts for 50% of that. So what can we do? You know, nurses have a great opportunity to help with prevention. So we look at, number one, the causes of stroke, which is increased blood pressure, increased cholesterol, diabetes, smoking, stress, diet. So again, great place for nurses to become, to work in prevention of chronic disease. If we look at the worldwide statistics in relationship to stroke, there are 15 million people who suffer from a stroke worldwide each year. 5 million die, 5 million are permanently disabled, which is staggering. And increase in blood pressure contributes to more than 12.7 million strokes worldwide. And we also know that blood pressure is the main cause for increased risk of stroke among people with diabetes. So we know that diabetes causes atherosclerosis, which causes then the blood pressure to rise. So again, prevention, that is a staggering number, 50% from stroke, chronic diseases, stroke, accounts for 50% of the deaths. That's a very large number. And our access to insurance, of course, plays a role in that. So if we have access to insurance, we're going to get more preventative care than if we did not have insurance at all. Evaluating healthcare reform, the U.S. produces many significant advances in medical technology and biomedical research. The healthcare delivery system is fragmented, wasteful, inefficient, and it's very expensive, so it's going to be difficult to sustain. When we look at the lags that prevent us, we have several lags we talked about before that prevent us from being identified as a healthy country. We know that having access to insurance is one of those issues. So we need to constantly, that's a constant surveillance, of course. Employment rates is going to affect the accessibility to insurance. So with lost jobs, for example, lost job, you'll have a loss in the insurance. And then we also have inefficient income to purchase insurance privately, which is very expensive. The means, what does that mean for us? That means that there's going to be a larger share of government that's budgeted to absorb that healthcare cost. Health information technology can, the advances that we have, can decrease healthcare expenses through lowering administrative costs that's related to record keeping and provision of data to compare effectiveness, helping identify root causes of problems and identifying ideal staffing problems. So it does help us to look at computerized, computer technology can help us look at trends and allow us to make some decisions based on the information that we can analyze from that, looking at those trends. The Affordable Care Act, it was actually meant to, you did this information on your own, that the Affordable Care Act was meant to address the three key components of healthcare costs: access and quality. The purpose was to help to ensure better, more affordable, and more equitable healthcare for all people. For many years, clinical hospital-based medicine has separated itself from public health community, which is primarily concerned with prevention measures and the health of the population. So in 2018, the Institute of Medicine, they address resource needs and ways to meet those needs. Of course, recognizing the importance of prevention is one of the keys. Also, identifying these resource needs was essential for them to see how we can get sustainable healthcare for the entire population. Increased health literacy. National Patient Safety Foundation found the fact sheet in 2018 that reported 26% of adults in the US are at risk due to limited health literacy, and higher rates of health illiteracy are found among the lower income individuals who qualify for Medicaid. Also looking at that same demographic group, they identified that lower socioeconomic status, limited education, and people with mental and physical disabilities were in that demographic that were eligible for Medicaid. The issue comes with finding it difficult for making informed choices and having difficulty completing the forms for eligibility, and also having problems initiating their own care. Public opinion. It's a reciprocal relationship between public opinion and politics. Public opinion helps to drive political decisions, and politics help form public opinion. So we already mentioned, which makes this interesting if you think back what we talked about before, is that politics is also influenced by special interest people. So it's very hard for people to make decisions based on what is given to them, so without having facts. So that's the key. One of the things nurses can do is to help provide facts so patients can make informed decisions. We know that change requires letting go of the familiar and accepting something that is strange and unknown. So change can be very difficult, but again, with facts, it makes it a little easier for decisions to be made. We also can look from other countries, looking at examples from abroad. What are the positive and negative outcomes of healthcare payment systems of other nations? The US could design a system that ensures personal freedom while supporting those most in need. So just ideas that have been put out there, challenges that we're going to see in the future. And we're going to talk a little bit about what you can do, what opportunities that you will have for nursing reform. So in 2011, 21 nurses were among the 73 healthcare professionals that were selected through the CMS, which is the Centers for Medicare and Medicaid Innovation Center, and were recognized as innovative advisors. They were given a test project. They wanted them to use or achieve the aim of better health, better care, and lowered cost through continuous improvement. With the passage of the Affordable Care Act, there was an increase in those clients who sought for health care. Okay, so they have more access, so that we have the supply versus the demand. So we had an increase in the need for advanced practice RNs because of this increase in demand. Okay, there's also was additional demands of qualified nurses in other healthcare fields. So nursing is not only at the bedside, there are other things that nurses can do as well. Nursing informatics is part of the increase need, case management, as well as the nurse navigator. The nurse navigator is interesting. It is a very interesting role. And I can see where, a lot of patients could use a nurse navigator. It's very difficult to make it through the system if you're not familiar with healthcare at all. And then add a disease process on top of it, like cancer, for example. That is very draining in a whole lot of ways, physical and emotional. So the nurse navigator is a medical professional that use their clinical experience. They use their training to help guide patients and their caregivers, to help them make informed decisions, and to collaborate with multidisciplinary teams to help to coordinate that patient's care. So it makes it smoother for the patient to move through the system, especially when they are, very uncomfortable maneuvering within the system, or they have a disease process that really is very draining. So a lot of patients could use this assistance. Nurses need to remain vigilant and getting involved in politics and legislation of nursing, particularly at the state level. So nurses are the largest group of providers of care who directly impact client outcomes. It is your professional responsibility to educate yourself about the facts of healthcare debate. If it has been shown that if more nurses join their primary professional organization, such as the American Nurses Association, It would give nursing one of the largest and the most powerful political voices in the country. The public trusts nurses too. So the public trusts nurses to be advocates for their best interest. And in the Gallup polls for the last 10 years, nurses have been rated as the most trusted and honored professions. So they're rated #1. So definitely an opportunity for you to be able to make a difference. The healthcare system is designed primarily to treat acute illness or injury. However, today the healthcare system is evolving and it's providing high quality care for chronic illnesses and adapting to those behaviors and those personal issues of the aging population. This growth in the older population, they coined the term silver tsunami. Not sure how I feel about that one, but it increases. Is just to indicate that there is an increase in the demand for health services. So the increase in the older population is going to increase the demand for health services focused on chronic disease, comorbidities, and the unique health promotion needs of our older population, our older adults. We know that the view of our older patients is that if they are living independently, then they're in good health, which is where most patients want to be. They want to be in their own environment for as long as they can. So that's typically how, that's typically the view. As baby boomers become 65 and older, we're going to see more than 37 million people in that group, which is 60%, will have one or more chronic conditions by the year 2030. Chronic diseases, obesity, diabetes, coronary artery disease, COPD, dementia, and the list goes on, dementia and cancer, osteoarthritis, depression. So there's a lot. So the reality is the chronic diseases have no measurable cure. So basically the treatment is to, what we're doing is treating the symptoms and trying to slow the progress of the disease. The older population has more hospitalizations, more admissions to nursing homes, and a higher likelihood of losing the freedom of living on their own. Therefore, also then puts them at risk for experiencing low quality of care. Comorbidities, which we know morbidity is, it refers to the condition of being in a disease state or in poor health. When we look at comorbidities, so more than one, so multiple morbidities, it causes the individuals to have longer hospital stays, which makes sense. It kind of compiles. All the major health organizations have identified that obesity and diabetes are the major health concerns. Chronic disease accounts for more than 36 million deaths per year globally. And as I mentioned before, 7 out of 10 Americans die from chronic diseases, with stroke being 50% of all deaths. 25% of people with chronic conditions, they're limited in one or more activities. So we have a need for better self-care. As people age, their ability to perform ADLs often decreases, and it depends on what type of illness or impingements that they might have on their physical or their mental function. The majority of adults prefer to reside in their own community or their home as long as possible. It keeps them independent and it gives them a sense of comfort and belonging. And what they found is that states who support or invest in those home support systems for elderly have reduced the number of clients that receive long-term institutional care. And overall, what happens is it lowers the spending in their Medicare programs. So there's a lot of technology that keeps patients in their home. They have systems that track their movement and systems that provide reminders for medication administration. Nurses who come to the homes. So there's a lot of opportunity to keep patients in their home as long as they are safe. Healthcare costs and coverage. Healthcare expenditure in the US, it's neared 3.3 trillion in 2017. 3.3 trillion in 2017. There's more than 13 times the 256 billion that was spent in 1989. So at that time, it was 10,348 that was spent for each US citizen. The largest portion of expenditure is Medicare and Medicaid. Understanding the difference between the two benefits. One is Medicare is a federal government sponsored healthcare program. It was developed primarily for citizens that are over the age of 65, those that have end-stage renal disease, and those that are disabled, persons who are eligible to receive Social Security benefits. So not all disabilities, but those who are eligible to receive Social Security benefits. Medicaid is primarily for low-income families and individuals. Employers, they're faced with increased expenditures and premiums for family coverage for their employees. So they tend to hire part-time employees who are not required to be covered. So what does that do? The unemployment rates do drop, yes, but the jobs are still at a low end of the pay scale. And then there's also an increase in coverage by Medicaid. So the employer is saving money by decreasing their employer's time frame to 29 hours, for example, and they don't have to pay for the insurance. However, again, it is picked up somewhere. So as your amount of money that is earned per year decreases, then it puts you into a different, different category of eligibility. So Medicaid would kick in at that point. There was a healthcare ruling. The Supreme Court upheld the Affordable Care Act in 2013. It was in favor, it did have favorable effects for seniors on the Medicare, which prevented them from decreasing in their coverage for seniors. Mobile acute care teams have better outcomes for the elderly clients. It produces improved outcomes for hospital readmissions, fewer adverse effects or events, shorter lengths of stay in the hospital, and higher patient satisfaction than when the patient did not receive care from a mobile acute care team. A mobile acute care team provides hospital level care in the patient's home. It's a team of doctors, nurses, other professionals that treat and monitor the client's health. And then they continue to monitor for 30 days after their client is well enough to be discharged from this daily care. So the key there, making sure that our clients do not return to the hospital setting. Those readmissions, we want to try to keep them healthy and out of the hospital within that 30 days. So there's a benefit to that too. There are rewards for good outcomes. We don't get the reimbursement if the patient is readmitted within 30 days. So it's incentive for us to take better care of our clients and making sure that we do some prevention and some education, paying close attention and monitoring our patients much closer than just discharging them and not having any further communication. Healthy People 2020 is a program that's working under the Department of Health and Human Services. It focuses on improvement of health for all American, all the total of the American population. So the goal is to promote quality of life, healthy development, healthy behaviors across the lifespan. Disease prevention and health promotion with appropriate goals and objectives which are measurable. So it does provide that comprehensive information for that disease prevention and health promotion. And it's going to help with appropriate goals and objectives with that within a measurable time frame. Now, with moving into a new decade, there are new objectives and that have been set for Healthy People 2030. Population growth. The population, America's population has increased between 0.7 and 0.9% yearly for the past 10 years due to, in part, by the increase in lifespan of the population. However, we still rank only 26 out of the world's 35 wealthiest nations in life expectancy. Our median average for men is 76. And women average of 78.7. So looking at increases of lifespan, what the causes for increase in lifespan is expanded health care or health insurance coverage, controlling infectious disease, immunizations, and antibiotics, improve air quality, providing contaminant-free drinking water and safe food, and public efforts to address health hazards, opioid abuse, gun violence, tobacco use, secondhand smoke, non-use of seat belts, and unsafe motor vehicles have all contributed to the longevity. Current research focuses on the most effective ways of using intervention or programs that are affecting chronic disease, such as diabetes and arthritis. The growing elderly population in the United States is having a major economic consequences for the country, especially federal and state programs that help support the healthcare of this group. Low income, the median age or the median salary or income for an elderly man is $15,000. Women, $8,500. 11% of the elderly population lives below poverty level, and another 27% is categorized as near poverty level. So very difficult for the healthcare if you would not have the Medicare in place. Long-term effects on nursing. The nursing shortage becomes more pronounced as older adults seek healthcare. The median age of nurses in 2017 was 50, so that is up from 46 in 2010. That that indicates that there's about 50% of the nursing workforce is nearing retirement age. The projections for the shortage is anywhere from 200,000 to 800,000 RNs by the year 2025. Schools of nursing, they're not able to meet the demands that are created by other nurses who are retiring, and the increased number of the elderly clients that we have to care for. Why is that? Two of the top, one is the retirement age and shortage of the faculty. So a lot of our shortage in nursing education is because of the finances. You know, a lot of people, when you get to further education, they're not going to take a drop in pay to be able to be an educator. So a lot of times it is finances that keep people from going into nursing education. The other is our ratios. We have specific ratios that is, you know, regulated, that we have a certain amount of students per instructor, and that's set at the state level. And then when we look at that regulation decrease in the faculty, you know, the number of faculty that we have to look also at the number of clinical areas that we can provide that experience. Straining the healthcare system. As people age, typically their healthcare needs increase due to chronic disease. There's, you know, we have a strain already that stresses the healthcare system. The nursing shortage is going to become worse. Working environments become stressed, forcing nurses to work long hours, which leads to long-term fatigue, accidents, injuries, and job dissatisfaction. And then unfortunately, we end up losing nurses this way. So nurses begin to leave the profession, which makes the nursing shortage even worse. We do have regulations by some of our you know, organizations that try to help provide a safe, you know, safe working environment for our nurses. The American Nurses Association recommended that nurses not work more than 12 hours in a 24-hour period and not more than 60 hours in a 7-day period. We also have a lack of geriatric specialists. There is a need for practitioners who specialize in elder care. There are nursing programs that offer advanced degrees and certifications in gerontology for nurse practitioner. But again, we have the supply versus the demand. We also need to focus on integrated care. And what does that mean? We need to make sure you know what that means. It requires that chronic diseases are linked with preventive measures, such as involvement of families, screening, counseling, education, and also looking at those social determinants of healthy behaviors. It also involves optimizing cooperation among team members, including community services such as immunizations and outreach programs. The multicultural and multilingual settings, nurses need to be able to provide high quality care in those settings as well. The education needs of our older clients. Nurses need to be educated on the older population about their health. We know that elderly clients have limitations such as poor hearing and vision, poor memory, disorientation. So the nurses need to know the most effective way to, most effective teaching techniques for their patient. So we have to first, of course, do your assessments. You're not going to assume that they have all or any of those potential limitations. So you always assess your patient first, see what their needs are, and then come up with the most effective education plan for them. Of course, the goal is to then educate our patients and to help them with changing in their behavior. So that's kind of the goal. Some teaching techniques: continuous positive reinforcement, repetition combined with positive reinforcement, praise, a pleased look, or another type of reward. The nurse can become that patient's motivator. Disaster preparation for older clients. So we know that natural disasters have pointed out the special needs of elderly population in a disaster situation. They have mobility limitations and chronic diseases that decrease their ability to cope with major disasters. If you think about a patient who has COPD, they're on oxygen, and we have a disaster that takes out their oxygen, takes out the electric that runs the oxygen. What do we do? So we're going to be talking about disaster nursing later, and we'll touch on that information then, but it's just food for thought there. Appreciating the older population's spirituality, spiritual connections to remaining independent and within their own home. There are spiritual connections. Nurses can respond to and assist the client with psychological, physical, spiritual, and emotional support, providing spiritual strategies like empathy and open-ended questions. The nurse can help improve both the individual self-esteem and his or her relationship with other people and whatever higher power the person may acknowledge. Also, we can help elderly clients find meaning and hope in their lives. So students need to learn how to provide spiritual care to this population. Learning spiritual content in nursing school is similar to learning nursing theory or philosophy, because it's going to require that you analyze situations and you use nursing judgment in resolving complex issues. Just knowing that patients are more than just taking care of their physical health. It's taking care of their mind, their body, and their spirit. An example that was given to me is from a priest was that he had received a phone call from a family member whose father was in the emergency room and he was not doing well. She was distraught and wanted him to have the last rites. When the priest went to the emergency room to see the patient, the nurse had told him that they had a visitor policy that only allowed one visitor per day, and the patient had his visitor for the day. He negotiated, wanted to come back the next day to see the patient. In not so many words, the nurse had indicated that it would not do him any good because the patient would probably not be alive the next day. Luckily, that was not the case. The patient had survived, and the next morning, the priest was able to come back and be able to give that patient his last rites. So my point in bringing up this discussion is that we need to remember that, again, patients are more than just the physical care of that patient. We need to take care of their mind, their body, and their spirit. And a priest, in my opinion, should not be viewed as a visitor, but part of the healthcare team, just as a chaplain or anyone who is supporting that person's spiritual health. So this is a great way for nurses to be advocates for their patients. Go to your supervisor, explain the situation, and advocate for that patient to be able to have that spiritual leader come into their room and provide the care that they have requested or the family has requested. Transition of care. Moving a client from one setting of care to another. So for example, home health to a hospital or assisted living facility, or from the hospital to the home to home health or rehab setting. The challenges for clients and their families is half of the elderly adults experience a medical error after hospital discharge. So between 19 and 23%, they undergo an adverse event, with medication errors being the most common. So another challenge is the increased self-care responsibilities related to shorter hospital stays. Discharge planning, it needs to begin at the time of admission. So we undertake, that multidisciplinary team needs to get better facilitated for proper assessment of the needs of the client and their families. The key to safe and effective transition care is setting up for follow-up visits prior to discharge. Follow-up visits, they usually take place within 2 weeks of the patient's hospital discharge. It should be sooner depending on the client's status. The follow-up appointments can result in lower rate of client readmission and 30-day mortality. So those are key evaluation benchmarks for hospitals. So follow-up appointments are extremely important. We can also use telephone follow-ups as an effective way as well following discharge. Ineffective communication, so making sure that we have good communication is what we want. Ineffective communication at the admission and discharge can lead to premature readmissions and increased morbidity. So I'll assess a full assessment of the elderly client's sensory, their cognitive abilities. It needs to be conducted upon admission. So we need to know about poor eyesight, hearing, poor comprehension, or failing memory. At discharge, the client should receive a list of their discharge medications that he or she is to take at home, with a list of the common side effects and instructions for self-administration, making sure that we have it written in common words, so words that they can understand. The Joint Commission actually recommends that patient education materials should not be any higher than the 5th grade level. We also want to make sure we point out any changes from the pre-admission medications, especially if we needed to discontinue a medication that the patient still has at home. So discharge is not the end of the healthcare provider's work and responsibility. It really should be viewed as a closure of the gap between the inpatient and outpatient care. So having that well-planned and effective discharge transition, it helps to close that gap. Medication risks. Medication errors are the most common type of adverse events during transition and care. Medications change. Medication changes can occur while they're in the hospital setting, and the patient may not even realize. But acute illness may cause that provider to hold certain medications, change long-acting medications to short-acting medications, discontinuing others, or changing dosages. The medication history is important on admission, and a comprehensive list needs to be completed prior to the patient's discharge. Discussion forum and details will be posted. please look for your announcements.